Good morning, everyone. I'm not sure how many folks here look at literacy through the lens of public health. I know that my friends up here on the panel do, and I know how important the issue of literacy is to health and to public health. We heard Johan say that yesterday, right? That literacy is one of the key social determinants of health. So, literacy affects health outcomes in many ways. It affects your knowledge, like what you know about health and medicine and disease. It also affects health behaviors. We know that folks who have low literacy tend to have more risky health behaviors. They tend to use less preventive health measures. We also know that literacy affects employment, and employment affects health. If you are underemployed or not employed, you probably have less access to health insurance. You probably have less income to purchase medicines and so on. So maternal health, which is the topic of the paper today, is one of the key indicators of a society's health. So without further ado, I'm going to introduce the researchers in the paper. And yesterday we had a discussant sitting what would have been to my left. We don't have that today. You all are going to be our discussants. So pay attention, get ready to ask really good questions at the end. All right, so it's my pleasure to introduce our panel. Jane Seymour is a doctoral candidate, and I can tell you, Jane, I just defended my dissertation 2 weeks ago. It's possible. You can do it. It feels really good to be on the other side. She's in the Department of Epidemiology at Boston University, and her research focuses on modifiable social factors like literacy and how they impact women's reproductive health. Rosie Frasso, who is sitting next to Jane, is the Director of Education in the Masters of Public Health program at the University of Pennsylvania, one of my many alma maters. That's what happens when you're old, lifelong learning. You tend to go to a lot of schools. Jane's research, Rosie earned her PhD at Penn School of Social Policy and Practice, and her interest is in maternal child health and society, human development, and health. And then Ian Bennett from the University of Washington is a professor in the School of Medicine, and he studies social determinants of health. Ian's interest is in risk variables and their role in the life course of vulnerable populations, in particular in the role of literacy in women's health throughout life. So I'll turn it over to the panel.
So when we think about social within the health realm, and I'm sure that there are parallels and areas where we might be a little bit different with it across the fields. But with regard to social factors influencing health, they're the kind of standard ones that have been around for a long time. Demographers have pointed this out for a long time. Things around socioeconomic status like income and education, which from my perspective are it's sort of they're great, but they imply a lot, but they're not as necessarily as modifiable as something like a skill, and true for demographics as well. It's hard to change race, ethnicity, and these are markers rather than modifiable kind of factors. And literacy for me was particularly interesting from that point of view. In terms of mechanisms or markers, thinking about the world from the point of view of someone's full life trajectory, I think is incredibly important and really revolutionary and critical to health and public health policy because of the fact that we have been so focused on reacting to health outcomes rather than preventive health kinds of perspectives on things. And things have changed a lot. There's been a big influence from the pediatric and pediatric world in terms of influencing this, but we have a certain way to go. If you think about the human being from the perspective of the life course, you have folks who are, this is a cartoon, of course, very simplified. I don't have adolescence in there and all sorts of other things, but if you think of child and adult and the reproductive years, demographers normally define as 15 to 45. That pretty much nobody has, there are some, but from a percentage point of view, there are very few people below 15 and above 45 having children. So those are the reproductive years, and you have all of these points that have potential inputs. The preschool years, the school years, young adulthood, middle age, and the older folks. I always wonder if elderly is the right term to use. So I hope I haven't offended anyone. Sorry, I don't remember. I don't remember who made this slide. I'm sure it wasn't me. Older adults. Sorry. So anyway, each one of these points are particular points of intervention, which potentially can deflect the trajectory of folks' health. But and this has been shown with some nice economic modeling as well, and you guys, I'm sure, are very familiar with this from the other areas of workforce and lifelong kind of successes, that the earlier the input, the easier the deflection, the less expensive the ability to deflect folks' trajectory in a more positive way. Trying to expand this a little bit, these are this educational focuses of preparedness, and then moving to achievement, getting people through as many years of school as possible, and hope without inflation of credentials, hopefully, and then you get into the adult education world, which is a really interesting one to me. But then there are these challenges from a life perspective and also from a health perspective with regard to parenting, grandparenting. Then there's the economic self-sufficiency as well. And then the challenges which overlap with health issues. We know that there are outcomes with regard to chronic illness and depressive symptomatology, that really can start actually in young adulthood, that are associated with differences in literacy. And so those have been areas that I've been particularly interested in. Okay, so as far as thinking about childbearing, and childbearing, it's sort of like mortality. It's easier to get that number from various statistical areas, and you can get someone to say how many kids they've had. It's harder to say other things like, how many times have they been pregnant, for example, is a much tougher number to get because of miscarriages and other differences in actually getting from being pregnant to having a kid. People remember it better too. So anyway, the childbearing is an interesting outcome, and it is one that has huge implications, of course, for folks outside of the field of health. And the number of kids that we have influences many things around how a society performs and what the future is, tax bases, all those sorts of things. But from a health point of view, childbearing is critical because of just health utilization. It's the number one reason for someone to be hospitalized under the age of 50, men or women, is having a baby. And it is, for folks under the age of 50, it is also associated, while it's a very natural thing to do, an important thing to do, it has its risks associated with it, and it is a source of both morbidity, meaning injuries, and mortalities for women both within the United States and the rest of the world. So there are points when we sort of think of the number of kids in terms of benefits to an individual relative to risk. There are decreasing benefits to risk, ratios as someone goes along in life, but there are increased risks early on. So it's a complicated sort of thing, and it's not all just good. There's some hard things about it as well. So in terms of predictors for increased childbearing, the low educational attainment, low socioeconomic status, and race ethnic minority status have all been associated in the U.S. With and a number of those in the world with increased childbearing overall. With regard to public health, low literacy is associated with poor health outcomes in general. That includes things like being able to, actually starting with mortality, literacy is an independent predictor of mortality among folks who are over 65. Interesting kind of factoid, but further earlier in the pathway, We know people are less likely to be able to understand their medications, take their medications correctly. That fits in what Iris pointed out, the health literacy realm. There are also poor health behaviors and increased risks, people falling off ladders because they're working in more dangerous kinds of occupations, for example. All those things that make sense within a conceptualization of how literacy might influence health overall. The risk for health outcomes is independent of more traditional risk factors like educational attainment. So statistically, you see the influence of both those factors, but they actually have independent risks. And literacy in general is a more precise measure of health outcome risk than educational attainment is. With regard to risk factors for low literacy, there's again low educational attainment. Which comes first is an interesting question. No non-native speakers in the sending nation. So being a non-native speaker in the nation where you're testing their literacy. Race, ethnic minority status, poor health status, low socioeconomic status, and increased age. The largest pool of, well, you guys know this, the largest pool of lower literacy folks are within the older Americans. Literacy in childbearing, there is a literature that kind of underlies our work that was mainly from the developing world, showing that educational inputs are associated with, well, first of all, that's low educational attainment is associated with higher fertility in the lower income nations, and educational inputs are associated with improved timing of childbearing, and that is usually associated with lower childbearing overall. We've also, that relationship though has been understudied in the US from my perspective, and we would put a reasonable amount of work into trying to change that, and have shown that, for example, that among teenagers, that in a prospective way, that those with lower literacy are at age 11, so before childbearing normally starts, have higher risk of having a child before the time that they're 20. So in the teenage years, also that's associated also with lower risk of graduation and all the kind of relationships that occur there. So we were very interested in using the PIAAC data to extend this work to also thinking about how that might fit within the perspective of the international, or the international perspective. Is that true in other high income countries in addition to the US, and thinking through what the consequences of that might be with regard to thinking about literacy, the relationship of literacy to these outcomes. And while we tend to think about in terms as health providers normally think in terms of bad things, bad outcomes, childbearing is not really. I don't want to give the impression that childbearing in itself is a bad outcome. You do have increased risk as childbearing increases. So we have a paper that's now under review that looks at longitudinally in the United States the risk of someone having 5 or more children, or grand multiparity, which is associated with poorer outcomes. But what we're really interested in here is how can knowing something about how literacy influences childbearing be helpful for policy discussions around the impacts of educational and other kinds of policy inputs, and also immigration policies, et cetera, in terms of what happens to the childbearing overall of the nation. So we'll start. I'm going to hand over to Rosie some discussions about what we're thinking about in terms of mechanisms and some of the analysis we did.
Thanks, Ian. I do remember having children, just to state that up front, although I try to forget on occasion. So I'm asked to talk to you about literacy as a potential mechanism and why we decided to dig into these data in the way we did. So as been stated already, literacy does directly affect health. That's been established in the US and across the globe. But does literacy influence other relationships that we know affect health? Whoops. Okay. And so does literacy mediate the relationship between other risk factors and health outcomes? So let me just pop this slide back up here. And in the effect of literacy and healthcare use is something that has been examined among the elderly in the U.S. and across age groups. As a moderator, literacy may have an impact on the relationship between other indicators or predictor variables and childbearing or other health outcomes. So does literacy interact? Does literacy account for the association of other risk factors in childbearing? And is the effect of literacy and care use on health outcomes in the elderly? That has been established and something that people have been looking at. Okay, so as I was saying, literacy is important. So does it interact with other predictive variables as a mediator of those relationships or as a moderator of those relationships? And to do that, like it was suggested earlier today, we, as others do, employed a model. This is one of our favorites in public health. It's Anderson's model for predicting healthcare use and utilization among vulnerable populations. We adapted this model to help us understand and explore these data, and we decided that we would look at one of Anderson's components of the model are predisposing health factors. And we wanted to look at literacy in that box as a predisposing factor for long-term impact on childbearing. And we also wanted to look at self-reported health among folks in these data sets. So we were able to examine both of those independently as they are associated with the outcome variable of childbearing, but also we extracted literacy and employed mediation and moderation analyses to explore how that impacted the association between self-reported health and childbearing. So the model does a nice job of explaining where we went with these data and allowed us to sort of frame our understanding of the analysis and help frame our understanding of the findings. So I'll hand it over to Jane at this point.
Great. So as Ian said, okay, awesome. So as Ian said, we really saw the PIAAC data as an opportunity to really delve into the relationships that Rosie just described. And as has been mentioned today multiple times, we really saw the benefit of being able to look across many different nations, and particularly in our case, high-income nations. As Ian has said, these relationships have been examined in kind of lower income nations, and having the opportunity to look at these relationships in a cross-national fashion was really exciting for us. Furthermore, it's a really large data set and uses a precise and validated literacy measure. So these were all benefits in our mind. So we had two questions that we went in, kind of dove into the data looking to answer. So the first is literacy associated with childbearing in OECD and partner countries? And the second was, in these countries, does literacy work as either a mediator or a moderator in the relationship between self-reported health and childbearing? So first things first, we just really want to thank the AIR team, and particularly Katie and Saida, who kind of took our analysis plan and really brought this project forward. So thanks to both of you for that. So our study population, we included the following OECD nations and two partner countries, Cyprus and the Russian Federation. Based on some data limitations, we did exclude Canada, Australia, Austria, Estonia, Germany, and Finland. But the 18 countries that you see listed were in our final study population. So we first started by looking at basic study population characteristics. So we were most interested in the mean number of children reported by the PIAAC and the PIAAC literacy score. One thing that we did kind of just to validate and check to see if things made sense was to compare the PIAAC mean number of children with the World Bank's total fertility rate. And we did see that they were highly correlated. We didn't expect them to be exactly the same because the total fertility rate looks at total fertility. So after a woman has reached the age of 45, and women in our study population were a variety of ages, but most under the age of 40. So they, we didn't expect these to be the same, but we were glad to see they correlated. This is a data check and our data makes sense. So first things first, we found a significant inverse association between literacy and childbearing across all OECD nations. We found a non-significant but inverse association between literacy and childbearing in Cyprus. So as you can see here, all of the relationships were significant except in Cyprus and the Russian Federation. I'm sorry, that's cut off. Essentially what these coefficients are saying, we'll use the United States as an example, but what this is saying is that if you were to increase somebody's, this is a simplification, but if you were to increase somebody's literacy score by about 159 points, they would have one fewer child. So we're just seeing that, yeah. So what we're seeing is that as literacy score increases, total number of children decreases. So furthermore, as it was expected, we saw a significant positive association between literacy and self-reported health. So as literacy increases, self-reported health also increases. So there was also a significant association between self-reported health and childbearing. So those with poor or fair self-reported health had fewer children, and those with excellent and very good self-reported health had more children. And at least one of those two relationships was significant across all OECD nations and partners. So next we dove into this moderation analysis. And when you're looking for moderation, we've reiterated here what moderation is in our model. So first you look to see if literacy is related to childbearing. And as I just showed you in this study population, it is. We then look to see if self-reported health was related to childbearing, which I just showed you it was. And then the final step is to see if self-reported health and literacy together create differing effects than the two do individually. So statistically speaking, we were looking to see if an interaction term between literacy and childbearing was significant. And overall, for the majority of countries, we did not find a significant interaction term, so we didn't see evidence of moderation. For mediation, again, we ask, is literacy related to parity and is self-reported health related to parity? And then we create a model that includes both literacy and self-reported health, and we see if literacy is still significantly associated with childbearing, even after controlling for self-reported health. And then we see if self-reported health is less related to parity after controlling for literacy. And we did find those things for the majority of the countries. So there was some evidence that mediation was happening in this population with this relationship. So, just to reiterate, we found that literacy is significantly inversely associated with childbearing across OECD nations. So, as women increase in literacy, they tend to have fewer children. And this is consistent with results from low and middle income countries. As I said, there was no support for a moderation hypothesis, but there was evidence to support a mediation hypothesis. So what does this mean? This means that we believe that people who are examining childbearing in OECD nations should consider literacy, both in terms of a traditional explanatory variable where literacy predicts childbearing, and also as a potential modifier of these predisposing factors such as self-reported health. We believe that literacy is a modifiable variable. It influences health and economic independence, and it has an impact across the life course. So we really see, important intervention points in literacy. And in terms of mediation, we see that literacy may lie on the pathway to childbearing. So it may explain some of the relationship between predisposing factors such as self-reported health and total childbearing. So again, the strengths of this study are just that we had a big data set that allowed for comparison across countries that used a precise and validated literacy assessment. There are, as there are with most studies, there are a few limitations, and the number one limitation is that this is cross-sectional data. So we were kind of assuming some temporal relationships And we think that, we see some evidence that those temporal relationships exist, but we would really want to go on and examine these in a study population that was followed over time. And then finally, childbearing was self-reported, and this childbearing variable did include stepchildren and adopted children. So there are, with that comparison to the total fertility rate, we assume that, that's probably not they're totally changing the numbers, but that is a limitation of this study. And then there was potential misclassification of the outcome, which is what I just said. And I don't think I'm going to go to the next slide because I think that's going to bring up the next person.
And if I can just add a couple of comments about the mediation versus moderation, just to clarify what we mean by that. So mediation is a way of thinking of, does literacy lie some way in the pathway of a relationship, for example, with self-reported health and the outcome of childbearing? So, does it explain some of the relationship? And someone with someone who has lower self-reported health has lower fertility, or has higher fertility. Let's see, someone who has lower self-reported health would have a higher or lower fertility based on their relationship with their literacy as well, and you can swap those variables around. Whereas moderation, which is something that we actually did see with that teenage study I mentioned to you, for example, Latinas in the United States, Latina teenagers who have lower literacy have a much higher impact of that literacy on the risk of having a teenage childbirth than African American or white teenagers. So that's what we mean by a moderation or a interaction. So we did not find evidence for that, at least looking at the variables that we explored in this analysis.
I will thank the panel for a wonderful presentation. And I know we have a few minutes for questions. I just wanted to make one possibly rhetorical comment. Johan spoke yesterday about the consequences of lacking skills, right? So I guess what I think about is how can we use this data or these data to further interventions, and what other issues that are available in the PIAAC data set could we think about, like income inequality, for example, and how is that impacted by literacy, and how does that impact fertility and women's health over the lifespan? So it's a fascinating study. It's a wonderful study unto itself, but I also see it as a great starting point for really mining the data. Absolutely. Yes, please.
Yes. Thank you. It's a great study. I'm really happy to see people using PIAAC for this, because I think it's important. Let me see if I can enlist you in a campaign to stop the misconception about literacy and health. And here it is. Your analysis is absolutely right. But the biggest finding in all of health, and certainly all of fertility, is the number one variable is education, right? The problem with focusing on literacy is not scientific. I totally agree with your finding, and it is mediating the education. The problem is what policymakers do with that. And here's what they do with it. They go, well, it's really expensive to educate people. What does literacy really do? This is what scientists tell us is really the action. Oh, I know what it does. It gives people facts. Let's give people facts. It's cheap, right? So you have the tragedy that unfolded in Africa with HIV. We spent billions and billions of dollars at giving people facts, all right? And here's what happened. So we were in Ghana collecting data on cognitive functioning, education, people's understanding of HIV. And we were talking to a man who was unschooled and illiterate, but he handed out these facts, and so we knew him really well. And part of the questionnaire was causes of HIV. And we said to him, here, we're going to list some things. Tell us if it causes HIV. And we said blood transfusion. And he said, yes, that's correct. And then he said, but not if you wear a condom. Mm-hmm. All right, now there's a lot of those kind of tragically sad things. And now what What that means is that that gentleman did not have a working theory of the disease. So the problem with focusing on literacy policy-wise is it gets stripped down, dumbed down. So why don't you do this? And PIAAC's perfect for this. First of all, I suspect you would find the exact same results with numeracy. Why don't you start to call it cognitive skills or cognitive abilities that you get primarily, most people in the world get this primarily through education, right? And expand the imagination of policymakers around what's happening when people can read, when people can do numeracy, and the metacognition that goes along with that. That, I think, are some of the real causal connections between education and health. So, great, keep doing the work. I'm not trying to be negative about your work at all. But see if you could expand that to get it beyond, let's just give them facts.
I find your comment really interesting because, it's exactly for the reasons that you outline that I have been focusing on literacy rather than education. And I'll tell you why, education alone, because I certainly consider education the way that you impart literacy skills. However, there's pretty good evidence that we've come across that there is not a direct correlation between the credential that somebody gets, using the language that I've just been given here, and someone's skills. So there's a correlation, but and what I mentioned, the precision of the risk associated with health outcomes is the literacy measure gives us a better, more precise measure of that risk. There's a more error associated with the educational attainment that someone has. So, to the degree that, I have just had a different kind of working definition of what literacy is, which is absolutely a reflection of cognitive skills from what policymakers might have, then let's clean up language or something of that sort. But we're saying the same thing. I just really think it's interesting, and I'll have to be more cognizant of what people might think of, because I don't think of facts as being literacy. I think of facts as, just as you described, isolated facts that need to be pulled together into something much more complex.
If you did numeracy with the PIAAC data,
Yeah.
or you did them together,
Mm-hmm.
construct, I think that might help people understand that these higher levels of thinking compared to somebody who has none of that is really what's driving the relationship. And the reason it's important to unpack education is because all the demographers have education. They don't have PIAAC data.
Right.
Right? So with PIAAC data, we can start to say, this is why your sacred finding over and over again is happening.
Mm-hmm.
And you're absolutely right. It's better to have those direct cognitive kind of functions.
Yeah.
We can make the education effect completely go away with those kinds of cognitive. So just expand it.
Just to throw in there one additional cautionary comment is that cognitive skills has the baggage in my world of IQ, so I usually am having to fight that battle, which is why I go to literacy rather than so there are a lot of different things.
Let's go ahead and move on to the next question.
Hi.
Hi.
This is Laura Salganic, and I'm going to actually elaborate on what Dave said, that another area of behavior that's associated with schooling is the idea of being an autonomous actor and making decisions for oneself. And I think those are also related to childbearing, and that's another part of like an underlying theory of what schooling provides. And I think in developing countries, you also get this is not as much true in the US, but you get this idea that it's because people can read that their fertility rate goes down. But there's also the whole idea of being, and I see you're shaking your head, being an autonomous person who actually can make decisions for oneself is another really big impact of school that we almost don't even see looking in the United States. Thank you.
We actually have someone online that wants to ask a question.
Great.
to Skype on, or
Yeah, yeah, we have a few people listening in.
Great.
I think.
Sorry, I don't think I can.
I think we can hear you.
Can you hear me?
Yes.
Oh, great. Okay, excellent. This is Julie McKinney. Thank you for the presentation. It was really interesting, and thanks for letting me join online. I was just curious as to whether you found a difference between countries in the strength of the relationship between literacy and childbearing or health overall. From what I've seen in the data, it seems that that literacy is a stronger predictor in the U.S. of health outcomes than it is in other countries, and that's something that I've been exploring in some research as well. So I was just wondering if you found that in this study as it relates to childbearing and overall health.
So, we can pull up. Yeah, we can.
I guess it depends on what you mean by
Right.
the strength. Do you mean that there's a higher correlation or a more powerful, in our case, our regression coefficient for the relationship?
Yes.
Yeah, there is a distribution, and
For sure.
Jane can talk about it.
For sure. So, I mean, I think the outlier here, which unfortunately got a little cut off, is the Russian Federation, which is like a whole order of magnitude smaller. But otherwise, we're seeing a spread of coefficients between, negative 0.002 and like negative 0.009. So there is some spread.
Yeah, and those do account for the spread in the, they correlate and account for the spread that you see in the actual total fertility rate,
Right.
which seems like a small number to anyone but a demographer who thinks it's huge. So.
So we have time for 2 more questions because we're running a little bit late this morning. Thank you, Julie.
I just wanted to point out that there's a way to reconcile David and Laura's comment. If you look at the framework about what predicts task difficulty, in the bottom 2 it's locating and cycling, which are the sort of the idiot's guide to eat your leafy green vegetables and whatever other nostrums we provide. But if you go to the level 3, it's integrating and then generating information. And those are, if you can talk about the tasks in those terms and what people face, then you can get around this circularity.
Sure.
And we were also having a chuckle thinking about the causal pathway of women reading books in bed, so you know what's not happening.
We cut that diagram out.
All right, and then our final question, please.
David Osher from AIR. I want to continue in the Baker-Selgonic, and I could not identify the last person's comment. I think as we talk about cognitive, there is also the importance of what Heckman and others have badly named, not conceptualized as non-cognitive, that end up being caught in what we're talking about and have particular relationships to health outcomes. And it's both those aspects of social and emotional skills that help us self-regulate, deal with relationships and so forth. It's also those attributes that also get conflated there as well, which may give me more sense of hope and things like that. But some of them are potentially accessible, I think, having walked in when Laura was making her talk before, in what is badly also named as the background data. And so it seems to me when we're talking about literacies and cognitive factors, I think that's right, but it's also a broader sense of what are those different factors that interact with life course behavior, whether it's job performance, whether it's post-secondary performance, lifelong learning performance, or whether it's health performance.
Well, thank you all very much, and thanks very much to the panel. It's a wonderful paper.
Thank you.